pleasure to welcome you to session 3 of our conference. We are delighted to introduce Dr. Mohammed Jamal. Dr. Jamal holds the position of Associate Professor of Surgery at Kuwait University, where he also serves as the Program Director for Bariatric Surgery Fellowship at KIMS. With expertise as a consultant surgeon, he brings a wealth of experience and knowledge to his role. Please welcome him.
I would like to thank the organizing committee for giving me this opportunity to present to you this talk on the various options for weight loss. Now, if we look at all the interventions available now for the treatment of obesity, it all starts, of course, with the behavioral modifications by counseling, diet, exercise, self-monitoring, stress management, and sleep. If we look at the pharmacotherapy, there is a huge revolution in that. Currently, there are about 15 medications coming in the pipeline. If we look at the current medications available in Kuwait, the most effective in terms of are the injectables, not the oral medications. And there would be the liraglutide, the semaglutide, and the tirzepatide, which we will talk about more later in the talk. And if we look at bariatric surgery, the top one in terms of weight loss that can cause 95% excess body weight loss would be the biliary pancreatic diversion, which we are now performing in the form of an operation called SADI, which will be of interest to you as biochemists because the nutritional deficiencies would be much higher with that surgery. So far in Kuwait, we have done only about 30 cases of the SADI operation. And then when you go down in terms of the nutritional deficiencies, you will have the gastric bypass, and the least that would cause any malnutrition would be the sleeve gastrectomy, which is the most commonly performed surgery in Kuwait and all over the world. Talking about diet first, diet don't work. I'm sorry to say that, but there is no single randomized control trial with a minimal follow-up. And by a minimal follow-up, I'll say 1 to 2 years, that shows that diet works. And you know, according to evidence-based medicine, we should be looking at the randomized control trials. This is one of the trials published in the New England Journal of Medicine in 2008. And you can see that most patients will start losing weight in the first 6 months, but then most of them will regain the weight. And if you look at the Look Ahead trial, which costs about $500 million to perform and produced many publications, in that trial they had around 5,000 patients with type 2 diabetes and a BMI above 25. And that the intervention was very simple. So basically, they saw the patients, in summary, 46 times in the first 6 months, counseled by a specialized doctor with interest in weight loss. And then they also supplemented them with meals. They monitored their physical activity. And with 10 years of follow-up, you can see that most of the patients regain the weight. So diet would cause around 4 to 5% of total body weight loss. But I get my patients always, when I talk to them about this, they would tell me about the Biggest Loser program. So this is a picture from the Biggest Loser program. I think it's in the 6th season. And at the end of the program, most of the patients would lose the weight. And there is a study published in obesity. Sorry, this is the only slide in Arabic. There is a study published in obesity, which is an impact factor of 10, a very prestigious journal in obesity. They looked at season 6 participants in 2016. And what they did, we always knew that when you diet, your metabolic rate will go down. But the question in this study was, if you stop dieting, do you go back to your original metabolic rate, or do you remain at a low metabolic rate? Now, this is the table summarizing the study finding, and basically what you can see there is that most of the patients, the pointer, okay, that's fine. So you can see here that most of the patients, their basal metabolic rate went down to around 1,900 from 2,600. They all lost weight in the first year, After 6 years, they all regained the weight. Actually, they regained all the weight within 2 years after the program. And what was very interesting in this study is that their metabolic rate was still slowed down even at 6 years after the surgery. So from a mean metabolic rate of 2,600 went down to 1,900, remained at 1,900 at 6 years after the surgery. So I would tell after the program. So that's why I would tell my patients who dieted so often before coming to bariatric surgery that they may have a worse response to the bariatric surgery in comparison to somebody who did not go into those yo-yo diets. If we talk about the bariatric surgical devices and procedures, they are mainly divided into two families, which is the restrictive families and the malabsorptive families. The malabsorptive family would cause more nutritional deficiencies, and the commonest procedure performed in Kuwait currently would be the single anastomosis gastric bypass or the mini gastric bypass. Raw wide gastric bypass is performed less commonly. If we look at the restrictive procedures, sleeve gastrectomy is a restrictive procedure, and it is the most commonly performed surgery in Kuwait. And if you look at the sleeve gastrectomy, it's simple. We are tubalizing the stomach, making the stomach a shape of a banana, and we resect around 70 to 80% of the stomach. There is no malabsorption to be mentioned in the sleeve gastrectomy, but when we look at later slides, we will show that you might get a vitamin B12 deficiency or iron deficiency in the sleeve gastrectomy, but the other nutritional components will not be lowered down by that surgery. In the raw wide gastric bypass surgery, there is a small gastric pouch, and then there are two anastomoses, one between the stomach and the bowel, and another one between the bowel and the small bowel. And in the raw wide gastric bypass, you have a bypassed duodenum, and therefore you might have more nutritional deficiencies. The single anastomosis gastric bypass, which is also called the mini gastric bypass, it is the most common, it's the commonest performed bypass operation currently in Kuwait, and I think in the Gulf. In that surgery, there is a small gastric pouch, but it's a long gastric pouch. And there is only one anastomosis between the stomach and the bowel. There is also a bypassing of the small intestine, but it is thought to cause more malnutrition than the raw wide gastric bypass. The operation could cause most of the nutritional deficiencies and could be of interest to you is the SADI operation that I talked about in the beginning of the talk. And in that operation, it's similar to the mini gastric bypass or the single anastomosis gastric bypass. However, we are keeping the pylorus. So there is a long stomach, we are keeping the pylorus, and we have only a common channel of 250 or 300 centimeters. So the food will be absorbed only in the last 3 meters of the small bowel, and it might cause more nutritional deficiencies, including micronutrient deficiencies such as copper, zinc, and selenium. Endoscopic gastroplasty is gaining ground. It is not a surgical procedure per se, in which there are no wounds, there is no cutting of any sort of the stomach. We do it endoscopically by suturing the greater curvature, and by doing that, we are reducing the size of the stomach by 50 to 60%. This is the MERIT trial published in the Lancet, and in that trial, they showed a weight loss of around 11%. If we compare the different bariatric procedures, the best impact on the diabetes resolution would be the raw wide gastric bypass or the sleeve gastrectomy. To a lesser extent, it will be the ESG, which is the endoscopic sleeve gastroplasty, in which we are just suturing the greater curvature. Bariatric surgery is associated with sustained weight loss even over 15 years. So there are studies showing that, including the Swedish group study published in the New England Journal of Medicine, in which we can show a sustained weight loss even over 15 years with bariatric surgery. In terms of diabetes remission, there are multiple studies published in high-impact journals, some of them randomized controlled trials, showing a very good resolution of diabetes following bariatric surgery that can reach up to 85% resolution at 2 years of follow-up. But what about the risk of bariatric surgery? If we look at the, before I talk about the risk, I want to talk about how bariatric surgery increased the lifespan. So it's basically by preventing fatal and total cardiovascular events, which has been shown in multiple studies. And also, this is an important study regarding patients with liver disease. In Kuwait, we currently have probably the highest volume per capita in terms of liver cirrhosis due to morbid obesity and type 2 diabetes. And this study is very important in that regard, published 2 years ago in JAMA, where they looked at 650 surgical patients with liver biopsies, pre-intervention and post-intervention, comparing them to 500 patients who were non-surgical and had liver cirrhosis. And basically, at the end of the study, they showed that there was a major liver outcome reduction from 9% to 2%, which is huge in terms of liver cirrhosis patients. This would give a result better than even a liver transplant. If you look at the complications, leak and bleeding are the major ones. DVT and pulmonary embolism is less than 1%. Nutritional deficiencies are rare with sleeve gastrectomy, along with dumping syndrome. Internal herniation will be more common with the Roux-en-Y gastric bypass, as well as marginal ulcers and gallstone disease. If we look at a summary of the nutritional deficiencies, we can see here that it's rare to have severe nutritional deficiencies in the sleeve gastrectomy, but will be more common with the BPD, which is the SADI operation. The SADI operation, or the biliopancreatic diversion, will commonly have several nutritional deficiencies, including micronutrient deficiencies. And probably Dr. Abdulrahman will talk about some of what he saw regarding that in the ICU. But with the sleeve, that is the commonest procedure currently performed, mostly what you might get is the iron deficiency or the thiamine deficiencies, especially in the first few months post-surgery. Now, what about the risks of bariatric surgeries? If we look at this study from the United States, looking at the mortality rates of 8 different procedures in patients with type 2 diabetes, you can see that the Roux-en-Y gastric bypass risk of mortality was better than even a laparoscopic appendectomy. So we have came a long way in terms of the safety of bariatric procedures. Again, this is another study looking at complication rates in 8 different procedures in patients with type 2 diabetes. You can see that the Roux-en-Y gastric bypass was safer than a laparoscopic cholecystectomy, a laparoscopic appendectomy, and a knee arthroplasty. Who are the candidates currently for bariatric surgery? In Kuwait, we are still using the 1991 regulations or the protocol, in which we are doing bariatric surgery for a BMI above 40 or a BMI above 35 with comorbidities. But there are new guidelines published in 2023 that are not applied yet in Kuwait. And in that, in the new guideline, there is a reduction in the BMI requirements. So a BMI above 30 with comorbidities will qualify for bariatric surgery. In terms of the balloons, the commonest balloon performed in Kuwait would be the ellipse balloon, which is a swallowable gastric balloon that can be defecated within 4 months after the insertion. This is one of the first studies on this published by our group, comparing the balloon weight loss with longer follow-up, and we found that the average weight loss with the balloon would be around 11.5% in terms of the total body weight loss. but most of the patients will regain, especially if their BMI was above 35. So if we summarize all the treatment options available for obesity, it will be diet and exercise, which can cause 5% weight loss. Balloon and endoscopic sleeve gastroplasties can cause a weight loss of between 10 to 15%, and the gastric bypass or the sleeve, which can cause a weight loss in between 30% to 35% of the total body weight. Pharmacotherapy is in between, but now with the high dose of tirzepatide, we are getting great results, reaching to 15 or 20% of the total body weight loss. If we look at the anti-obesity medications, what we have in Kuwait is the semaglutide and the tirzepatide, but they are very hard to get hold of. There is one in the pipeline undergoing currently phase 2 or phase 3 trials, the retatrutide, which can cause even a better weight loss than the tirzepatide, around 25% of total body weight loss. This is a busy slide with different medications, and you can see that in those slides, tirzepatide 50 milligram is the best medication currently for weight loss. Most of these medications exert their effect through the brain, not through the gut. What are the indications for pharmacotherapy? A BMI above 27 with comorbidities, or a BMI above 30, or weight regain following bariatric surgery. If we look at different studies for liraglutide, the weight loss is around 6%. If we look at semaglutide, the weight loss is around 15%, but most of the patients will regain the weight back. The hottest drug in the market now is the tirzepatide, and this is a slide summarizing the SURMOUNT randomized controlled trial. You can see the average weight loss was 15% with only 5 milligram of tirzepatide. And if you go to 15 milligram, you get around 21% total body weight loss, but it's not much different from the 10 milligram. So what I do now is I try to keep the patients in the 10 milligram. I will not go to the 15 milligram because the side effect will be much lower and the weight loss will be very similar. Again, if you stop those medications, the patient will regain back. Yesterday, by coincidence, we published the first paper, I think one of the first papers in the world, on the use of tirzepatide for weight regain post-bariatric surgery. And with that, we achieved a 15%. We achieved a 15% total body weight loss, which is, it's down there, 15% total body weight loss with tirzepatide after 6 months, which is similar to revisional bariatric surgery. So in our series of revisional bariatric surgery that was published, we achieved 16% total body weight loss at 6 months following weight regain, following sleeve. And with this, we were able to show similar results with medications. In terms of the complications of pharmacotherapy, the tirzepatide will have the least side effects, and mostly it will be nausea, vomiting, diarrhea, headache, or abdominal pain. Do not give it if there is a family history of medullary thyroid cancers or in patients with multiple neuroendocrine neoplasia. There are in Kuwait, nodules in the thyroid nodules are common. So although it is not in the guideline to do a thyroid ultrasound, I'm frequently doing that for patients prior to starting medications. Because if they get a nodule after your medication, for any reason, they will relate it to the medication. And if you do it prior to that, you will have it documented. So this is the last slide, the summary slide. Basically, the best obesity management can be accomplished in a multidisciplinary management team. Behavioral interventions do not work. They are good for prevention and good for as an additive to the proper treatment. It's an excellent option for patients with morbid obesity. It's very safe and effective. Pharmacological options are gaining ground, and they can be really excellent in bridging the treatment gap in patients who don't want to do bariatric surgery. Thank you again for the opportunity.
Thank you, Dr. Mohammed. Any questions?
So, yes. So if you look at the literature, diet do not work for the morbidly obese. So I'm talking about BMI above 35. Now, if we talk about somebody who's 16 years old, who never dieted, never exercised, playing video games all the time, and they just become normal by, like anybody else, by exercising, by eating better, then that might be successful. We don't have randomized trials on the teenagers or the young individuals. But if we talk about somebody who is above 25 with morbid obesity, most of the randomized trials will show that patients who regain the weight. Even if you look at the medications trials, most of these patients are regaining the weight after stopping the medications. There was a device, I forgot the name of the device, but basically the company went bankrupt, and in that device they would do a hole in your stomach, like a gastrostomy tube, but a very small one. And they will give you a suction device. You would eat and then put the suction device to make the food come out. So the patients were not eating, basically, with that device. The weight loss was only 10%. And that you can see across all the interventions that do not include surgery, a weight loss of around 10% by the best diet available. The problem is not the weight loss, it's the weight regain. So obesity is a disease that is marked by maintaining the set point. So your body will always maintain the set point and get your weight back to normal. There is a movie I saw last week called Society of Snow. You should see it. It's a Spanish movie about a rugby team that was lost in the Andes. It's a true story. They had a plane crash in the Andes. It was minus 30 degrees. They had no food, and they survived for 4 months. They got discovered 4 months later. And you can see that it is for these situations that our genetics are made. We are made to avoid starvation. And what we are living now in the past 50 years is something that humans never experienced for 1 million of years. 95% of the human history was prior to the invention of agriculture. So 95% of the age of our gene was lived when there was no ready-made food. You should always hunt. And that's what we are made of. And that's why the current environment that we are living in is an environment that is not compatible with the human nature. By the year 2000, last week also, there was a study published in The Lancet showing that 20 to 30% of the world population is obese. It is expected that by the year 2100, 50% of the world population will be obese. So it's something that we are going to live with.
Next, please join us as we welcome Dr. Abdulrahman Alfares. Dr. Fares, he graduated from the University of Birmingham Medical School, UK in 2003, and then pursued training in internal medicine and critical care, where he obtained MRCP UK in 2011, followed by residency in internal medicine in McGill 2012, critical care at the University of Toronto in 2015, and obtained ABIM and FRCPC in internal medicine and critical care in 2016 and 2017, respectively. He then pursued further training in extracorporeal life support and critical care echocardiography at the University of Toronto and obtained certification from the National Board of Echocardiography. He is currently the chair of the Department of Anesthesia, Critical Care Medicine and Pain Medicine, and the director of Kuwait Extracorporeal Life Support Program, Amiri Hospital. Welcome, Doctor.
Thank you very much for the introduction. I should have sent a much shorter bio. This is too long. So I've been tasked, thank you very much for the organizers and for the committee for inviting me to talk about this issue. It's very difficult, it's very challenging. The literature is not rich or great, but I'll try to navigate you through what nutritional deficiencies that might be seen in the bariatric population in the ICU post-operatively. So I have no conflict of interest to declare related to the subject. We'll talk about the global burden very briefly of obesity. We've heard some of that so far by Dr. Jamal. The local situation in Kuwait, types of surgeries and complications, very brief. and then concentrate on the micronutrient deficiencies, factors contributing to these deficiencies, what common deficiencies are out there that might lead to an intensive care admission. It should be extremely rare. And what are preventative measures and guidelines for laboratory work, which I've been tasked to talk to you about mostly. So we now, everybody knows and understands that the obesity pandemic or epidemic is global and it's growing in nature. And when we look at childhood overweight, it's been increasing dramatically globally, even in societies where thought to be having an exceptionally good diets that might prevent obesity. The WHO estimates that since 1990, obesity in adults have doubled, and in adolescent, it quadrupled. And in 2022, 1 out of 8 patients or people in the world were living with obesity, 37 million children under the age of 5, 390 million children and adolescents between 5 and 19 were overweight, with 160 million who are living with obesity, and 2.5 million adults overweight, with a large proportion of them living with obesity. So these are real numbers and realistic numbers that we have to live with and adapt with time. And when we look at prevalence in Kuwait, this is one of the earlier studies by the group from Dasman Institute, where they looked at the prevalence of obesity across the globe. And probably you've seen things like this in the news, where Kuwait is the number 10th country worldwide, with places like American Samoa and the Cook Island, etc., that labeled as having a global burden of obesity that is unbearable. And when we look at gastric bypass surgery, this is the work of Salman al-Sabah and group, where they reported their earlier experience of adoption of procedures. And you see, as Dr. Jamal mentioned, the sleeve gastrectomy and gastric banding is probably the more common ones, with Roux-en-Y and the others leading after that. And the more complex the surgery is, the longer the patient might need to stay in the hospital. So Dr. Jamal went through the different types. I'm not going to dwell there, but what we see in the ICU might be variable. Probably we see more, if ever happens, stomach leaks and sepsis, but nutritional deficiencies is one of the complications that you might face. One of the larger observational trials that looked at a proportion of patients who underwent bariatric surgery and what of them present in intensive care. Out of 12,000 patients that had been followed up, only a small, tiny proportion, less than 5%, might present to an acute care facility requiring an intensive care admission, with very, very, very small proportion of them that requires really intensive care. So if we look at nutritional deficiencies, we're going to concentrate on vitamins and minerals. And when we look at the literature where it supports where this data comes from, and we look at micronutrients deficiencies after bariatric surgery and monitoring, we want to look at pre and post-op for up to a year, and whether patients are compliant with replacement or not. We see concentrating on folic acid and vitamin B1, for example, and copper, but also we're not doing so great in vitamin B12, which I'm going to talk to you in more details later, vitamin D and calcium, that might present with some complications to hospital. And when these patients are even followed for longer, for 3 years plus, you see that the compliance with these nutritional replacement go down with time. And when patients are followed for a longer period of time, up to 10 years or so, the significant proportion of nutrition deficiency increases. And in a multivariate analysis to the factors that contribute to these deficiencies, Dr. Jamal left, but he would be happy to hear that the last surgeon visit is the only independent risk factor associated with those deficiencies. So patients are not followed up, not seen in clinics, and that's why they fall in that aspect from maintaining those nutritional requirements that they need. Further reasons for some micronutrient deficiencies is non-compliance with nutritional supplements, lack of follow-up, as I mentioned, some post-operative food intolerance, poor eating habit, vomiting, etc. So if we talk about, I have to give a disclaimer, I've seen maybe one case in my 20-year plus experience in critical care of somebody that I can elude their presentation to critical care with a profound neurological symptoms that I could elude it to a vitamin deficiency. But other than that, I haven't seen a single patient who present with these factors, maybe because the follow-up is much better than when these surgeries took part. But if we concentrate on the first vitamin that I want to mention, thiamine, it's absorbed by the jejunum, as you know, and maybe Roux-en-Y and the duodenal switch is the most common factors that might contribute to a poor absorption. But also stores might be depleted if you have a gastric band and patients are persistently vomiting, or due to stomach edema after sleeve gastrectomy. They might present to the ICU with a profound peripheral neuropathy and the extreme cases of Wernicke's encephalopathy when they present with confabulation, ophthalmoplegia, and ataxia, or to the extremes of Korsakoff psychosis, which is a complications of Wernicke's that we're going to talk about in a bit. Or even cardiomyopathy, where they would present with beriberi or wet beriberi. There is risk of free feeding that, as Dr. Jamal mentioned, and this definitely requires prompt diagnosis and parenteral replacement. When we look at Wernicke's, the data here is very scarce. It's all observational work. There's no randomized trials or high-quality evidence in this field at all. But when you look at Wernicke's encephalopathy and experience in this group, they see that the majority of patients present to them post-Roux-en-Y and sleeve gastrectomy with less in the other surgeries. And it's more common in females than males and more common in the younger ages between 21 up to, let's say, 50 years of age. So that's where you have to think more commonly if patients present with these symptoms. And when we look at during their post-operative period, you would see it may be more common in the first 6 months, with the numbers dwindling significantly thereafter. And when we look at Korsakoff as a complication psychosis, which is a neuropsychiatric disorder characterized by severe amnesia, executive problems, and confabulation leading to lifelong disability, when we look at MRI images, it's more common in people who present with these nutritional deficiencies. And when the management is suboptimal or the investigation is suboptimal, then patients have lifelong complications and persistence of these findings. So this is vitamin B1 or thiamine, which is probably one of the commonest deficiencies that might present to critical care. The second would be vitamin B12, which is binding to intrinsic factor, as you know, is secreted by the stomach and absorbed in the small intestine. Post-surgery deficiencies can result in inadequate secretion of intrinsic factor. It's also limited by gastric acidity or limited absorption, especially in the duodenum, if bypassed. It occurs as a long-term complications, not really acute presentations. And they might present to, again, the theme is neurological presentation. They might present to critical care with profound neuropathy that is unexplained, or myopathy, or even confusional state, where they have delusions, memory disturbance, and dementia. It required prompt investigation. You might need to measure methylmalonic acid with or without homocysteine, and intramuscular or intranasal regimen would be ideal to manage it promptly. Next would be folic acid. It's a complex dietary folates that is required to be absorbed throughout the small intestine and mainly by brush borders. And they might be aggravated by B12 deficiency, and that is required for the activation. Again, presents at peripheral neuropathy and myopathy, and replacement by the oral route is required. So these are really, if I had to summarize what the most common three vitamins that would be deficient that you might ask to investigate and justify to the lab to investigate it for me would be vitamin B1, B12, and folic acid. Next, we come to soluble vitamins, or fat-soluble vitamins, A, D, E, and K. they're very less likely to present to critical care with striking pathology, but maybe vitamin E might present with some neurological symptoms. And if you have a bleeding, uncontrollable bleeding or bruising, you might think of vitamin K as a cause. For minerals and trace element, this is the less common things. Iron and calcium is probably more studied and more commonly reported in the literature. But when we look, what we're more interested in the extreme situations that might present to critical care would be zinc, copper, and selenium deficiencies. They are more important for enzymatic cofactors and several of the biochemical pathways. I don't have to explain that more to the audience here. But copper deficiency per se might present with refractory anemia and myeloneuropathy, with sensory ataxia, and selenium deficiency might lead to cardiomyopathy and critical care admissions. And here we are really in the realm of case reports. So this is very, very, very low quality evidence here, but there are some reported cases of extreme severe pancytopenia and refractory anemia, or severe cytopenias consistent, similar to myelodysplastic presentation with some excessive blast that reverses completely with copper replacement, or when we look at selenium, where patients might present with cardiomyopathy, extreme anasarca, heart failure, and with the prompt diagnosis and replacement of selenium, the patient recovers and turns the corner within 3 months or so. Prevention is always better than cure. So as Dr. Jamal mentioned, a multidisciplinary approach is key. Adequate follow-up and surveillance is ideal. High index of suspicion to acute care physicians with the aid of laboratory investigation as well, and long-term follow-up and diligent follow-up with engagement of family and physicians. So if we talk about guidelines, I try to bring for you all the guidelines out there that is more informative to your field, what investigations that would be required from the laboratory or laboratory assistants. Sorry, this is very busy slides, but this is the largest guideline out there that is endorsed by the American Association of Clinical Endocrinologists, American College of Endocrinology, the Obesity Society, American Society of Metabolic and Bariatric Surgery, the Obesity Medical Association, and the American Society of Anesthesiologists. And here they recommend that you do B12 testing every 3 to 6 months, folic acid testing with iron, B12, vitamin D, and IPH, vitamin A testing every 6 to 12 months, and copper, zinc, selenium evaluation with specific findings. And that dependent on the type of surgery, you see it more common in the bypass devices or surgeries and the duodenal switch. And this table, if you want to reference it later on, extensively gives you details of what would be replaced and in what, and what's more common in what. And when you look at the British guidelines, so that's the North American guidelines, when you look at the British guidelines, it's very similar stuff. So they concentrate on folate, vitamin B12, vitamin D and calcium, fat soluble, trace element, etc. Very poor quality of evidence. Most of them are grade B, C, and D with lower quality. But anyway, this is from observational work, and the recommendation, again, is to test these things periodically. Similar things with the Francophone guidelines and the European Task Force for the study of obesity. And if I want to summarize it, this is a nice study that summarizes everything. In sleeve gastrectomy, I would do ferritin, transferrin, vitamin B12, folate, copper, etc. And when you go to the more extreme surgeries, you would require the addition of zinc, vitamin A, and copper, etc. So in conclusion, bariatric surgery is associated with long-lasting effects on obesity and associated diseases. Micronutrients are common and sometimes cause irreversible sequelae, and you have to be really diligent in diagnosing. Lifelong supplementation is the key. Some require regular sampling, and particular attention should be paid for pregnant women and adolescents after bariatric surgery, especially younger women, that they might be more at risk of some of the deficiencies that we had to mention, especially vitamin B1, and supervision with specialized multidisciplinary team is key. Thank you very much.
Our next speaker is Dr. Ahmed Alsarraf. He's a renowned lipidologist here in Kuwait. Dr. Alsarraf got his postgraduate training in medical biochemistry and was awarded a certificate in clinical lipidology by the National Lipid Association in the United States. He co-authored several publications in international journals, mainly in lipid disorders. He actively contributed to the familial hypercholesterolemia registry in MENA region and participated in several projects and campaigns to raise awareness to certain lipid disorders and non-communicable diseases. He is currently the lab director at the Sman Diabetes Institute and is also the faculty chair for the clinical biochemistry program in Kuwait. In addition, he is the head of the lipid clinic in Amir Hospital. Please welcome him.
Thank you, Dr. Mobarak, for this lovely introduction. Today, I'm going to talk about effect of bariatric surgery on lipid profile. As you know that we have two sources of cholesterol, that one comes from the food, which is only 20%, and 80% are produced from our liver. High cholesterol may lead to cardiovascular disease. For that, please don't listen to her.
لا تخافون من ارتفاع الكوليسترول الضار. أي دكتور يخوفك من ارتفاع الكوليسترول هذا معناه إنه هذا الدكتور بطل يقرأ من يوم تخرج من الجامعة. الأدلة الحديثة والعلوم والدراسات الجديدة كلها أثبتت عكس ذلك. شوفوا مثلا هذه الدراسة راجعت 19 دراسة أقيمت على 68 ألف مريض. خلاصة هذه الدراسة إن الناس اللي كان عندهم ارتفاع بالكوليسترول الضار عاشوا أطول من الناس اللي ما كان عندهم ارتفاع بالكوليسترول الضار. تخيلوا. والدراسة هذه تقول إنه كل ما زاد ارتفاع الكوليسترول الضار عندك وكل ما زاد فرصة حياتك وطولة عمرك. وهذه الدراسة تقول إن 50% ريدكشن انخفاض بنسبة الوفاة عند الناس اللي كان عندهم ارتفاع بالكوليسترول الضار. هذا يعني إنه الكوليسترول الضار لا يسبب الوفاة. إذا كان عندك ارتفاع بالكوليسترول الضار لا تخاف، وهذه الدراسات موجودة هنا كثيرة تدل على ذلك.
Why I start my presentation with this video? Okay, she said that hypercholesteremia will not cause cardiovascular disease, and you're gonna live longer. Unfortunately, it's not true. She has 1 million followers, and some patients, they listen to her, and they stop their medications because the knowledge that she received for the patients or to the followers that they are follow her. She has 1 million followers. And she is very active in the social media. But again, hypercholesteremia can cause cardiovascular disease. Please don't listen to her. Some patients, they go for bariatric surgery. Some patients go for losing weight. That's possible to decrease cholesterol. But unfortunately, not all the cases can decrease cholesterol by therapeutic lifestyle changes. Cardiovascular disease is the leading cause of disease, disability, and death. Worldwide, there are more than 18 million deaths due to cardiovascular each year. In 2016, the cost for cardiovascular disease only in America, around $500 billion. And by 2035, they are expected to increase up to $1 trillion. In Europe, it's up to $282 billion. Cardiovascular disease, atherosclerosis, is the most common pathological vascular changes underlying cardiovascular disease, and hypercholesterolemia, proven as a major risk factor for its development. Once you decrease by 1 millimole for LDL, you're going to decrease mortality up to 25%. Obesity is recognized as one of the most relevant public health problems in the world. This epidemic condition has nearly tripled since the 1980s. And it is associated with a wide range of comorbid conditions, such as metabolic syndrome, cardiovascular disease, osteoarthritis, sleep disorders, and unfortunately, certain types of cancer. It is estimated that up to 1.6 billion people in the world are overweight, and 400 million are obese and are responsible for an estimated 4 million deaths globally per year. Severe obesity is defined by a body mass index more than 40, as Dr. Jamal and Dr. Alfares said, and coexisting metabolic comorbidities, which could lead to substantially increased cardiovascular morbidity and mortality. It is associated with 10 years of life lost compared to normal BMI. Dyslipidemia is a common condition related to both severe obesity and cardiovascular risk. Patients with obesity is frequently characterized by high levels of triglycerides and LDL cholesterols and low HDL. In 1967, they found that obesity may lead to cardiovascular disease as one of the risk factors. And one of the Inter-Heart study that published in 2004, they found that obesity is a risk factor for cardiovascular disease in addition to other risk factors such as hyperlipidemia, sedentary lifestyle. Why is that? Because our quantity of food increased and our exercise become less and less with changes in a small amount. If you go with to the fast food, before it cost 1 kd, upper size, X large size, just add 250 fils. So you're gonna go toward with a more size. And here, unfortunately, everybody craves coffee mocha. Do you know how many calories in coffee mocha? The minimum is 300 calories. And if you drink 4 per day, it's gonna be 1,200 calories. The requirement for your calories per day is around 1,600 to 2,400 based on your body mass index. In Kuwait, unfortunately, and this has been published, published last month in Qatar News, Kuwait is one of the highest prevalence of obesity and overweight in the world. We are competing Qatar. Unfortunately, not with the soccer's, football, mabani, cliche. We are competing with overweight and obesity. Our youth, 24% of our children are obese and overweight. 78%, they found that we are overweight and obese. The prevalence of obesity in adults in Kuwait estimate 41% in men and 49% in women. 80% of our girls here fall in this region, 25 and 30 per BMI. Unfortunately, it's time to think differently about obesity. The management of obesity includes lifestyle modification, pharmacotherapy, and bariatric surgery, as Dr. Faris and Dr. Jamal inform us. Bariatric surgery is the most effective long-term therapy for weight loss with a concomitant beneficial effect of improving comorbidities and decreasing mortality. Bariatric surgery brings about a weight loss of 30%, and which is maintained over the long term, and this is the benefit for it. In the look ahead study, with analyze the effect of therapeutic strategy on lifestyle modifications, only 34% of the intervention group lost 10% of weight in the first year, and only 42% of these 10% who had a satisfactory initial response kept this weight loss 4 years later. On the other hand, pharmacological treatment for obesity achieved weight loss from 4 to 20%. A meta-analysis of Butchword included data from 136 studies with a total of 22,000 patients showed a significant weight loss in patients who were subjected to bariatric surgery with improvement in resolution or resolution of 86 to 70% type 2 diabetes and dyslipidemia respectively. All these beneficial effects led to the reductions in mortality of almost 30% at 10 years. Several surgical techniques were used and can be classified as malabsorptive or restrictive or mixed. As Dr. Jamal informed us, the bariatric surgery procedure were divided into restrictive procedures, such as sleeve gastrectomy and adjustable gastric banding, malabsorptive procedures such as biliopancreatic diversions with duodenal switch, and mixed malabsorptive and restrictive surgery procedures such as Roux-en-Y gastric bypass. Malabsorptive techniques such as biliopancreatic diversion reduce intestinal length and therefore reduce nutrient absorptions, while a restrictive techniques such as adjustable gastric band or ringed vertical gastroplasty become limited because of their results in terms of weight loss or the remission of comorbidities. The most commonly used technique nowadays are laparoscopic Roux-en-Y gastric bypass and laparoscopic sleeve gastrectomy, as Dr. Jamal. Both of these procedures have obtained similar results in terms of weight loss and comorbidity remission such as type 2 diabetes or hypertension. Roux-en-Y is a mixed technique that combines a partial exclusion of the stomach by means of the gastroplasty with a bypass of the duodenum with a proximal jejunum with the resulting effect of malabsorptions, while sleeve gastrectomy consists of subtotal vertical gastrectomy with the preservation of the pylorus, including a longitudinal resections of the fundus, the gastric body, and antrum of the resections comprise approximately 80% of the stomach, with a gastric remnant of more than 100 ml. So the effective of the bariatric surgery is in weight loss, carbohydrate metabolism improvement, improved lipid profile, and for these reasons, bariatric surgery has been redefined as bariatric and metabolic surgery. In the literature, approximately 60% of patients with severe obesity qualifying for bariatric surgeries have dyslipidemia. It's universally acknowledged to be better than conservative medical treatment in terms of weight loss and the remission of the several comorbidities with the resulting reduction in cardiovascular risk. Dyslipidemia caused by obesity is characterized by quantitative and qualitative lipoprotein alterations. The lipid profile alteration found in patients with high BMI are similar to those found in insulin-resistant patients with type 2 diabetes. The reduced capacity of insulin to inhibit the production of glucose by the liver, as well as favoring the use of the glucose by the muscles, leads to a state of hyperglycemia and hyperinsulinemia. Insulin is not able to inhibit lipolysis of triglycerides by the lipase lipoprotein in adipose tissue, so that the flow of adipocyte-free fatty acid to the liver increases, leading to an increase in the visceral fat. The increase in the fatty acid will lead to the increase in hepatic synthesis of very low-density lipoprotein. The obesity-related alterations of the lipid profile is characterized by increase in triglycerides and LDL and decrease in HDL. These abnormalities in severe obesity plays a central role in the development of atherosclerosis, contributing to the residual cardiovascular disease. Several studies have shown the effect of bariatric surgeries on lipid profile. The evaluation of this atherogenic profile after bariatric surgery has observed a fall from 32% to 63% in triglycerides and an increase in HDL around 12% to 39%. Similarly, a study evaluated the remission of atherogenic dyslipidemia 1 year after Roux-en-Y and the sleeve gastrectomy. Atherogenic dyslipidemia was presented 81% of 356 patients occurred by 3 months and 90% at 6 months, reaching 69% at 12 months after the surgical procedures. Likewise, HDL increased 6 months after bariatric surgery with a significantly greater increase in the atherogenic profile group. There was also an evident improvement in triglycerides in the first 3 months after surgery in both the groups, with a significantly greater reductions in the group with atherogenic dyslipidemia during the entire follow-up period. A recent published article, a retrospective study with a total of 123 patients were enrolled with a mean age of 48 and a mean BMI was 47. All patients were evaluated until 16 plus minus 8 months after surgery. All visits performed immediately before and after surgery. The practice provided a baseline visit, followed up by other visits 1 month, 3 months, 6, 12, 18, and 24 months after surgery, and then annually thereafter. Patients' weight and BMI significantly decreased after surgery, together with both excess weight loss and total weight loss, confirming the progressive decline of body weight and the maintenance of the surgery results. In addition, uric acid significantly decreased, as well as liver enzymes. Total and HDL cholesterol did not change that much after surgery, while a significant reduction in triglyceride was recorded, as well as increase in as well as decrease in LDL. Moreover, both LDL and non-HDL cholesterol were significantly reduced among visits. Significant direct correlations were found between total LDL, non-HDL, and triglycerides, and month elapsed after surgery. Similarly, a direct correlation was found between HDL and months after surgery. Interestingly, triglyceride and HDL serum levels were significantly inversely related to patients' weight, but not to BMI at each visit. Dyslipidemia prevalence decreased after surgery, and it was significantly predicted by patients' weight and total weight loss, thus confirming the decisive role of adipose tissue reductions in the lipid profile changes. The excessive visceral adipose tissue accumulation is associated with the increased whole body lipolysis and increased delivery of non-esterified fatty acid to the liver with overproduction of triglyceride-rich lipoproteins. Accordingly, cholesterol reductions after surgery is directly related to patients' weight, suggesting that the greater the weight loss, the greater the decline in serum cholesterol levels. Moreover, obesity is related to the hypertriglyceridemic state, high triglyceride, with metabolic abnormalities in all triglyceride-rich lipoproteins, and the liver plays a central role in determining these conditions. In fact, subjects with severe obesity show an altered hepatic fatty acid trafficking, intrahepatic fatty acid, and are shifted toward very low density lipoprotein and triglyceride productions rather than oxidative pathways. Furthermore, the bariatric surgery, such as RONY, determine an increase in circulating fasting bile acid levels. These changes in bile acid physiology after RONY likely support weight loss and problem sustained metabolic improvement in terms of glucose and lipid metabolism. Which one is better, RONY or sleeves? Regarding the different techniques of bariatric surgery, in the majority of the studies, RONY sleeves obtained comparable results in terms of weight loss and the remission of several associated disease over the short to medium term. One study with a 1-year follow-up concluding that the mixed technique improved all the lipid fraction, while the restrictive technique, although it had no effect on LDL cholesterol levels, had the same or more effect as the malabsorptive technique in increasing HDL cholesterol. In a study with a short follow-up period, RONY has been said to be superior to sleeves gastrectomy in how to improve the concentration of total cholesterols and the LDL. However, the short-term results for triglyceride and HDL are contradictory. The study by FIX, which include 45 patients in the RONY group and 55 in a sleeves gastrectomy with 1-year follow-up, found that the first group performed better in reducing total and LDL and raising HDL with no differences between techniques and triglyceride levels. Another study showed that RONY was superior to sleeves in terms of reduction in total cholesterols, and a greater fall was also detected in LDL. On the other hand, both surgical techniques were similar in terms of their result for triglycerides, as well as rise in HDL. Furthermore, very few studies compared RONY to sleeves gastrectomy over 5 years in terms of lipid profile. A randomized clinical trial, Sleeve Pass, 119 patients treated with the RONY and 121 patients treated with the sleeves gastrectomy found lower levels of LDL 5 years after RONY in comparison with the sleeves gastrectomies. The SM-BOSS studies also found a greater reduction in LDL cholesterol after the mixed technique, which is RONY, in comparison with the restrictive techniques. However, neither study found differences between the techniques respecting other lipid profile. Is there any factors that associate with the remission of the lipid profile? Little is known about the factor associated changes in lipid profile after bariatric surgeries. A study found that at a younger age, level of total cholesterol before the procedures and the laparoscopic RONY gastric bypass were associated with improvement in total cholesterols. The same factor, except age, were found to be associated with a reduction in LDL levels. An increase in HDL levels after bariatric surgery was associated with an older age, initial levels, and laparoscopic sleeve gastrectomy procedures. A reduction in triglycerides was associated with initial triglyceride levels and hemoglobin A1C. Another study evaluated factors associated with the remission of different lipid profile alterations at 5 years. The factors associated with the remission were male sex, Rho-NY, and the absence of initial treatment with statins. To conclude my talk for today, bariatric surgery is an effective modality for achieving significant weight loss and treatment for obesity and its comorbidities. It is not only allows sustained weight loss, but also are efficacious treatment to correct dyslipidemia in complicated obese individuals. This could provide a basis for clinical decision-making and help the clinician develop a personalized approach to managing obesity and associated dyslipidemias. In addition, these changes demonstrate benefits from weight loss after bariatric surgery, including decreased risk for cardiovascular disease, and finally, Rho-NY is superior to sleeve gastrectomy regarding the changes in the plasma concentration of total cholesterols. LDL, however, the results for HDL and triglyceride are contradictory. Thank you.
Thank you, Dr. Ahmed, for the wonderful session. Next, our speaker is Dr. Khalid. He's joining us from the Sultanate of Oman. He's a senior consultant medical biochemist and lipidologist. He's holding the position of head of clinical biochemistry department and lipid unit at the Sultan Qaboos University Hospital. He's the vice president of Oman Society for Lipid and Atherosclerosis, and also chairperson of International Atherosclerosis Society, MENA Africa Federation. Welcome, doctor.
Thank you very much for the kind introduction. Good evening, everybody. I know it's the last lecture today, and it's very difficult to keep everybody awake, but I'll try my best to make it more interactive and stimulating. I would like also to thank the organizing committee for the invitation. Today I'll be talking about the review of lipid guidelines. I know there were many guidelines over the past few years. And when you talk about the guidelines, it will be very difficult to follow which guidelines that I should really follow, which guidelines I should really practice in my country. So if we start actually with the lipid disorders, we will not talk about much today the details, but I would need to highlight that all the dyslipidemia that we will discuss today, the one that actually would lead to cardiovascular events, that's the atherosclerotic cardiovascular disease. These disorders can be either inherited through any genetic mutation, or it can be really acquired, and most of it acquired, the inherited only around 10 to 20%. Now, when we talk about guidelines, what are the lipid guidelines, or what are the guidelines actually in common? And why do we need guidelines, and which guidelines should we really follow? So the guidelines for any treatment, actually, they synthesize the best available evidence for treatment of that disorders, and more importantly, what are the best available medication to lower that disease. And another important point is not only a reduction of the LDL cholesterol, however, the most important point is a reduction of cardiovascular events. So they must be updated in accordance with the newly published high-quality studies, and we would see later on what studies are available for the different types of medication to treat dyslipidemia. Now, do we need the guidelines? Yes. Why do we really need the guidelines for any disorders? The most important point is really to help reduce variation in clinical practice. In the old days, everybody is treating lipids differently with different medications without any evidence of which one actually would reduce the most and which one would reduce cardiovascular events. Now, when you look at the guidelines, different guidelines, it's very important to see if they share the main evidences and what type of evidences. And you have to see which medication it has class 1 evidence and level 1 evidence. And the most important, actually, medication or most important treatment that comes from multiple randomized controlled trials, and it shows a clear benefit of reduction, not only LDL cholesterol, but also cardiovascular events. Now, as highlighted by Dr. Ahmed Alsarraf, cholesterol, is it really a fact? Is it really a hypothesis? It used to be a hypothesis. Many people, they say cholesterol, high cholesterol is harmful. So to answer many questions, is cholesterol harmful? Of course, no. High cholesterol is harmful. What we treat is hypercholesterolemia, not normal cholesterol. So it's very important to tell the population and patients, so do not think of cholesterol different than blood pressure or different than from glucose. So these are really a normal substance created by God for a certain functions, but very high cholesterol will lead to a high risk of cardiovascular disease. That has been shown by different evidences. Let me take you now to 3 types of studies that shows the strong relationship between the high cholesterol and cardiovascular disease. If you see the red line, this is from the randomized controlled trials, and usually they are around or over 5 years. So they are really short studies, and it shows you very well that a reduction of the LDL cholesterol will lead to a reduction in cardiovascular events. Then if you see the prospective cohort studies, usually over 10 to 12 years, but most importantly nowadays, what we rely on also the Mendelian randomization study, because you would see the whole life of that individual with the whole life exposure to LDL cholesterol. And if you see that the relationship is more stronger and steeper, and it shows you very clearly a high cholesterol will lead to a high risk of cardiovascular disease, and a reduction in that LDL cholesterol would result in a reduction of cardiovascular events. Now we know statins is the first line treatment. I'll come to statins later on. But if you see that different trials, around 21 trials in primary prevention and secondary prevention, it shows you clearly that a reduction of LDL cholesterol by statin would result in a reduction of cardiovascular events. However, you might argue that some patients on statins still they have repeated events. And the questions, are statins enough? Yes, they are effective, potent, inexpensive, and usually they are generally tolerated. However, they have a residual risk. If you see a meta-analysis of 21 trials, high-dose statin would result in a reduction of LDL cholesterol and then cardiovascular events, more importantly, by around 20 to 35%. However, then there is around 70% of risk are not addressed. And that's tell you it's not really still inadequate, and that's why we might need a combination therapy. But let us go back. Why does this happen? Why we have so many population, they are on statin, they still get another attack of cardiovascular disease? Many causes due either to suboptimal treatment, that's us, the physician. We start the patient on statin, go home, no follow-up, or even just yearly follow-up, and we don't follow any target or any reduction, percentage reduction in the LDL cholesterol. Sometimes the patient, they are not really compliant, and we have also refractory hypercholesterolemia. So you give statin, but they are statin resistant. Then we have a certain type of population that they need a high dose of statin and combination therapy, because even a high statin therapy as a monotherapy will not be really enough to reduce the LDL cholesterol to the needed target. Familial hypercholesterolemia, high-risk individual, and those patients with statin intolerance. So you would see now the paradigm shift in dyslipidemia management. We used to say a stepwise approach. Start with the statin, then add ezetimibe, then add a third medication. Is it really practical nowadays with those type of diseases? We will see later on from the randomized controlled trials. But it seems to be that monotherapy is unlikely to reach a very low LDL cholesterol. If you see later on the target of LDL cholesterol 1.4, and if you start with 10 millimole with patients with familial hypercholesterolemia, then you need 85% reduction in the LDL cholesterol. Before we go to the guidelines, let me take you through the available treatment for hyperlipidemia and the evidence that they reduce LDL cholesterol, and more importantly, a randomized controlled trial show you that it reduces the cardiovascular events. So the first treatment we have to remind ourselves, lifestyle. That's the diet and exercise. And when you were asking doctor about the treatment of obesity, is diet and exercise really beneficial, and is it really working? In the 30% with obesity, it might be difficult, but what about the 70% of the population? Yes, and that would come actually in prevention. For obesity, the new strategy of treatment will be really prevention. Prevent yourself from getting obesity. Otherwise, once you are obese, it's very difficult to get rid of it. Again, for dyslipidemia, lifestyle modification, heart-healthy diet, regular exercise, increased physical activity, that's really the core treatment of dyslipidemia. And then if it fails, then you would go to statins and then combination therapy. So if you see the combination therapy, what the available ones, either oral medication or injectable treatment. And the one with the stars, it means that we have an evidence they reduce cardiovascular events. We will go through them one by one, and then we'll come back the combination therapy. So if we go back, where do they work? Most of them, they work in the liver. Some of them work in the intestine, and some of them, they work in the plasma. So cholesterol, as Dr. Ahmed Alsarraf told you, that 80% is really synthesized in the liver, and only 20% is really absorbed from the food. So the first two treatment in the synthesis, statin, it's HMG coenzyme A reductase inhibitor. That's the rate-limiting step in cholesterol synthesis, and bempedoic acid in the step just above the statin. So those, they really reduce the cholesterol synthesis, then they deplete the liver from the cholesterol, and then you upregulate the LDL receptor to clear more particles. And then we have the PCSK9, either anti-PCSK monoclonal antibody or inclisiran, as I will show you later on. They are really inhibiting the PCSK9. What is PCSK9? PCSK9, you can look at it as the scissor that cut the LDL receptor. And the LDL receptors are very important to clear the LDL particles from circulation. So by inhibiting the PCSK9, then you are inhibiting the scissor, so you have more LDL receptors at the surface of the liver. And then lomipitide, it works as a microsomal triglyceride protein inhibitor and lipoprotein lipase inhibitor. It inhibits the NGPT3, then we inhibit the inhibitor. I'll go through them one by one through the other slides, and I'll show you which one is really shown to be effective and reducing the cardiovascular events. So till 2002, we had only approval for statin. So for the past 50 years, we had only statin. But since 2002, we had the first approval, FDA approval on ezetimibe. And then if you go 2012, 13, 16, 17, we started to see the PCSK9 inhibitors and the approval of these medication by the FDA. And now we still have two other medication on the way. They would be approved in 26, 27. So what is ezetimibe? So ezetimibe, simply, it inhibits the absorption of cholesterol in the stomach by inhibiting the Niemann-Pick-C1L1 like 1 receptors. So it's purely, it inhibits the cholesterol absorption. It reduces LDL cholesterol by 25% on top of a statin, and then we would consider it if we need another 25% reduction. However, if you need more than this percentage reduction, then ezetimibe won't be enough and you need another medication. Do we have evidence that ezetimibe reduced cardiovascular events? Yes, we had two studies, IMPROVE-IT and SHARP trial. So in IMPROVE-IT trial, you see clearly that ezetimibe on top of statin does not only reduce LDL cholesterol, but also it reduces the cardiovascular events. And in multiple studies in statin intolerant patients, if you give a small dose of statin plus ezetimibe and you compare it to high dose of statin, it will give you more or less the same reduction both in LDL cholesterol and in cardiovascular events. Bile acid sequestrant is one of the oldest medication. It is really effective to reduce it by 12 to 20%. It reduces the reabsorption of bile acids. And then by reducing bile acid, you will direct cholesterol to the synthesis of the bile acids. But due to the multiple side effects, especially the gastrointestinal upset, nobody is using it nowadays, especially sometimes, only sometimes in rare cases when you have a very high cholesterol in a pregnant lady, one of the safest medication in pregnancy. Bempedoic acid, this is one of the latest medication. It's the same as a statin. It reduced the LDL cholesterol synthesis, and then it reduced the LDL cholesterol by 17 to 18% on top of a statin. And again, the same as ezetimibe, you would use it if you need another 15 to 20% reduction in LDL cholesterol, or most importantly nowadays, we use it in a patient with a statin intolerance. Those who cannot tolerate statin, then the alternative would be bempedoic acid. Do we have evidence that it reduces cardiovascular events? Yes. So from this study, it reduced the cardiovascular events by 13%, and There is no increase in diabetes mellitus because many people with statin, they claim that we have a high risk of diabetes when you start a patient on statin. Again, as with ezetimibe, if you combine now bempedoic acid and ezetimibe, it gives you a very good reduction, especially in patients with statin intolerance. And if you combine the three, you would have a greater reduction. Now, the latest medication, PCSK9, these are injectable medications. So these are monoclonal antibodies or siRNA inhibitors. So they reduce the PCSK9 dramatically. And then the end result, you have a huge quantity of LDL receptor at the surface of the liver, and then you would clear more LDL particles. So we have two medications, alirocumab and evolocumab. They are injectable. They are given once every 2 weeks, and they reduce cholesterol dramatically above 25%. They reach 50% reduction. Do we have any evidence they reduce cardiovascular events? Yes. It is at 15% reduction on top of a statin. So these are one of the medications now proven that they reduce the cardiovascular events. Inclisiran, another injectable medication, it's the advantage of inclisiran that you would give it once every 6 months. And many patients actually now they are fighting to get inclisiran injection. Why would I get an injection every 2 weeks if I have another injection every 6 months? So it reduced the LDL cholesterol by around 50%, and usually we give it to those patients with poor adherence to monoclonal antibody. We have an evidence they reduce LDL cholesterol. Unfortunately, till now, we don't have any randomized control trial to show there is evidence of a reduction of cardiovascular events. It's still in the way, and then it will be really produced in 2026. Sorry, it seems to be the graph has been shifted down. So this is a reduction by 60% from yellow to the green, 60% reduction in the LDL cholesterol. Another medication are available, but they are very expensive, evinacumab. So evinacumab, actually, it is a lipoprotein lipase. This is when we talk about it inhibits the ANGPTL3, and ANGPTL3 is the inhibitor of the lipoprotein lipase. So you are inhibiting the inhibitor of lipoprotein lipase, and if you have lipoprotein lipase, working efficiently, then it would clear more VLDL particles to LDL, and those LDL will be uptaken by the liver. So usually now we consider these for only, most of the time, for homozygous familial hypercholesterolemia because they are really expensive, above 150,000 Kuwaiti dinar per patient per year it costs. Lomipitide, another expensive medication, but very effective in patients with homozygous familial hypercholesterolemia. It reduces the LDL cholesterol by 50%. As I saw you in the graph, it is microsomal triglyceride transfer protein inhibitor, so it would inhibit the assembly of VLDL particles, so they are not shipped out of the liver and no more LDL particles in the circulation. Evinacumab and lomipitide are really mainly reserved for patients with homozygous familial hypercholesterolemia, as they are also very expensive. The last modality I will talk about is the LDL apheresis. It used to be the standard of care of homozygous FH and patients with heterozygous FH, because in the era of a statin, it reduced only 50%, and patients with even heterozygous FH, the maximum you will get from 10 millimole to 5 millimole, but that's still really very high risk. However, in homozygous familial hypercholesterolemia, all the medication, they will give you only 20 to 30% reduction, apart from lomipitide that will give you 50% reduction, and you still need the LDL apheresis. That would be done twice every month, every 2 weeks, and it reduced the LDL cholesterol by 70 to 80%. But through all the time, all the life, then you would reduce the baseline LDL cholesterol from 25 millimole per liter to around 2 to 3 millimole per liter with the help of the other medications. Now, this slide would summarize what is really the efficacy and efficiency of the medication. If you use the statin, that will give you between 30 to 50%. However, if you see the oral medication, moderate statin plus ezetimibe plus bempedoic acid, that will give you 65%. But you have to be careful, multiple if you have patient on multiple medication, drug-drug interactions, and many side effects. PCSK9 inhibitors, that the injection will give you 60% reduction, and if you combine it with high-intensity statin and ezetimibe, that will give you 85% reduction in the LDL cholesterol. And those are all the evidences that it shows that those medications reduce also the cardiovascular events. Now, let us go through the guidelines. I will not go to the all guidelines. Let's start with the guidelines in 2019, and then I'll go through the latest guidelines. If you see now, you would see a very high risk, 1.4 millimole per liter. In the old days, it would be very difficult to bring a patient LDL to 2.5. What about 1.8 and 1.4? No way you would be able to do it with a statin alone. So those patients at the very high risk, any patient with already cardiovascular disease or familial hypercholesterolemia or patient with chronic kidney disease, then you should aim for 1.4. Diabetic patient will be high risk, and you need to bring the LDL below 1.8. And then the modern concept and the paradigm shift in dyslipidemia treatment, that you don't start actually just with one medication. So first of all, start early, you do not wait, and then treat much more aggressively and use combination therapy. So which patient should we use a monotherapy, and which patient should we really use a combination therapy? In the guidelines, it tells you, now you know how much it would reduce each medication, and you should calculate the baseline LDL cholesterol for your patient. Let's say that the baseline was 10 millimole for a heterozygous familial hypercholesterolemia. And what is your target? 1.8. How much reduction you need? 82%. Then you have to choose the combination therapy. If a low-risk patient, then you need to bring the LDL cholesterol by 20 to 30%, then statin medication would be enough. A diabetic patient, that you need to bring the LDL cholesterol to 1.8, rarely you would be able to reduce with a statin, but you need maybe statin and ezetimibe. So now the new shift in management of dyslipidemia, do not keep in mind that you should go step by step. No, you calculate the LDL, the baseline LDL cholesterol, and what is your target LDL cholesterol based on the guidelines, and then see what is the percentage reduction in LDL cholesterol needed, and then use either monotherapy or combination from the beginning. So if I need to reduce LDL cholesterol by 85%, it doesn't make sense you start with the statin as ezetimibe after 1 year, after another year, then you add PCSK9. By that time, your patient might have a heart attack. So from day 0, you start with whatever needed treatment, even if you need combination therapy from day 1. And that's now the new guidelines even for acute coronary syndrome. Why do we need to wait for PCSK9? So start with statin, ezetimibe, PCSK9 from day 1 post-ACS. Now, another latest guidelines, it was from the endocrine group, the American Diabetes Association and the American College of Endocrinology. I would not go through the guideline in detail, it's more or less the same. However, the endocrinologists, they were the first one to highlight that non-HDL triglyceride, they should also be used as a target. Most of the time we talk about LDL cholesterol. What about non-HDL cholesterol? In this guideline, they consider the non-HDL cholesterol as a secondary target. So immediately after the LDL cholesterol, if you meet the LDL cholesterol, look at the non-HDL. If non-HDL is not on target, then you have to optimize treatment. The same for triglyceride. Now, in our guidelines, we have written our guidelines for the Middle East. So we gathered for around 23 countries, and we have published our first guidelines in 2016, but again, we have rewritten our guidelines for Middle East in 2021. And we highlighted that we have also a very high risk and extreme risk. And we highlighted the importance of non-HDL. So we think in our region, non-HDL should be considered as a primary target along with LDL because of high prevalence of obesity, high prevalence of diabetes, high prevalence of metabolic syndrome. So that's why many times when we follow only the LDL cholesterol and it's on target or semi-target, many of our patients, they still get another attack of coronary artery disease. So we are highlighting in our guidelines that non-HDL should be used as a primary target along with the LDL cholesterol. And easy to remember, if you need to add LDL target, you add only 0.8 millimole per liter to your LDL. So if your LDL target 1.4, non-HDL will be 2.2. If 1.8, the non-HDL will be 2.6. So for all the risk categories. Now, even the European guidelines. So if you remember when say about the guidelines, it used to be every country, they have their own guidelines. And even in the country itself, every society, they have their own guidelines. Now the European altogether, they have their own guidelines, and the American, more than 12 society, they came together to release one also guidelines to make it really easy and to minimize variation. In the latest release, also by the European Society of Cardiology in 2021, they highlighted the important then. For high risk and very high risk individual, do not go step by step. From the beginning, start treatment. For high risk, statin and ezetimibe. What about the extremely high risk patient? The combination together, statin, ezetimibe, and PCSK9 from day one. Why would you wait for 3 months, 6 months, 1 year, and the patient is at a high risk or extreme risk of getting another attack? Now, we have seen many medications, either oral or injectable, but there is another important concept we have to keep in mind. This is one of the latest publications last year from Albrico Catabano and his groups. I wouldn't also go in detail about very high risk. They also insist that you use combination therapy from the beginning, but most important thing in this publication, that you have to be careful about which patients should you use which combination. Now, I wouldn't also go into much detail, but if you have elderly people at risk of statin intolerance or muscle pain, or if you have a pregnant lady, or if you have many patients with comorbidity and at risk of drug-drug interactions. So you have to be careful which medication, and this publication highlights which medication is really safer in this kind of population. Because many of us sometimes they might start combination therapy without taking into account what could be the potential side effects. Any patient, if you start combination therapy and get any adverse reaction, then you would lose that patient. So from the beginning, you have to be careful and look at any drug-drug interaction, and then you have to avoid this medication. Another concept, I don't know how much time I still have, 4 minutes, so I will just highlight about the importance of dyslipidemia in obesity, insulin resistance, and metabolic syndrome. In those category of patients, it's really a unique dyslipidemia. You would see that there is a high triglyceride, a high small dense LDL particles, and very low HDL cholesterol. And this is due to the insulin resistance. So those patients, if you take only LDL cholesterol and LDL cholesterol in target, and non-HDL, if you don't take into account, you would see that they are high risk. So if you see from the yellow lines that patient reaching the LDL but not non-HDL, they still have 30% higher risk than the other population. And that's why when I highlighted that for diabetic patient, obese patient, and patient with metabolic syndrome, you have to look at the LDL and non-HDL together. Why is that? Is it really the triglyceride or something else? It's really not the triglyceride. It is really the triglyceride-rich lipoproteins. They carry something else, we call it remnant cholesterol. So for the same patient, if they have LDL cholesterol is similar, but different category of triglyceride carried by VLDL particles, you would see the non-HDL is higher. Why is that? Because of the remnant cholesterol carried by these particles. And that's why very important to measure the non-HDL. Now, do we have any medications for high triglyceride? It reduces triglyceride and reduce cardiovascular events. The only medication till now from randomized controlled trial is really the pure EPA. Not all omega-3, not the combined one, is the pure EPA. It reduced the LDL cholesterol, it reduced the triglyceride, and it reduced the remnant cholesterol dramatically and ApoB, and it resulted in a 25% relative risk reduction in cardiovascular events. And that's why I didn't go to the old guidelines, but the 2023 for management of dyslipidemia in diabetic patients, they also highlighted the high risk. But most importantly, if you see class A, level A, start statin, and class A, evidence A, that PCSK9 is more stronger than ezetimibe in patients with diabetes. What about triglyceride? The only evidence we have is really a high dose eicosapentaethyl, that's the 2 gram BID, that's the pure EBA, and still the evidence if you see 2B. Why it is only a single randomized controlled trial? But what about fenofibrate? What about Omacor, that's the combined? We don't have any evidence, but if you have the only available medication you can use, but you don't have evidence that reduce the cardiovascular events. So in a conclusion, I can see that I have 1 minute. So lowering LDL cholesterol level is the most important pharmacological intervention to mitigate the atherosclerotic cardiovascular events. Statin, yes, the first line treatment and will still be the first choice. But with the new option, significant reduction LDL are now possible with combination oral and or injectable therapy. That's the end of my presentation, and thank you very much.
Thank you, Dr. Khalid. We will now open the floor for questions. I will remind you if you have any question, you can scan for the barcode. Our first question, instead of measuring vitamins, can we blindly give all patient oral supplements and that's it? It's for Dr. Abdulrahman. Yeah.
Of course you can replace, and you should. That's what surgeons usually do, or clinic follow-ups. But in extreme situations where you have a presentation with something profound, neurological or cardiac, then measuring instead of treating blindly with every single vitamin you could think of would be ideal.
Okay, thank you, doctor. This question is to Dr. Ahmed or Dr. Khalid. So recently, the use of GLP-1 agonists is increasing, even in young patients with, maybe we can say high normal BMI, when it's not overweight, and if their lipid profile is just on the upper border, they start treating with GLP agonists. Is it acceptable, doctor?
It's acceptable.
Any guidelines or anything just to, what is the appropriate guidelines to follow such patients? If BMI is 24.
Unfortunately, I don't have the details.
Okay. Because in private, they are really starting the young patients on semaglutide or Ozempic, weekly injections for 6 months.
It's better to be answered by Dr. Jamal.
Okay, doctor, thank you.
Because nowadays, some doctors, they prefer to continue for life. Some surgeons, they prefer to continue for 6 months, 12 months. Honestly, there is no clear guidelines for these kind of medications. How long you can keep it?
Thank you, doctor.
Is it safe and effective to use low-dose statins to prevent hypercholesterolemia or only for weight loss?
To use low statin in?
Low-dose statin to prevent hypercholesterolemia or just for weight loss?
You mean in everybody? No, actually, see. Now, to start a treatment with the statin, the first line treatment, we say it's to start actually with a healthy lifestyle modification. And then to start a statin treatment, you have to fall in one of the categories. So some of the patients, you don't really need to measure actually the risk. Diabetic patient with cardiovascular disease, familial hypercholesterolemia, they should be really started on treatment, and patients with chronic kidney disease. Otherwise, for the regular individual, then you have to calculate the risk using one of the risk score, either Framingham or Q-risk or the NICE guidelines. Then if you are at a higher risk, then you use the treatment. Otherwise, if you are not at risk, we should not really start any treatment with statin.
Can I continue? For example, if you have two measuring LDL above 5, start treatment. Don't wait, and don't do risk estimations. If patient around 4 millimole after therapeutic lifestyle, 2 measurements, start treatment, and don't wait, and don't go for risk estimations. Is that clear?
Okay, is the target LDL is the same for pre-diabetes as for that of diabetes?
Okay, so for type 2 diabetes, actually to start the treatment, then either you have a complication or you already completed a 10-year risk. For type 1, you might start type 1 at the age of 8 or 10. Then you have to complete either 20 years as a type 1 diabetes or 10 years plus any complication. But the target for patients with diabetes should be below 1.8 if there is no complication. But if you have any other micro or macrovascular complication, then the target will be below 1.4 millimole per liter. So we have really to be very aggressive in treating diabetic dyslipidemia.
What about pre-diabetes?
Pre?
Yes.
No. So for pre-diabetes, again, pre-diabetes, that will be metabolic syndrome. Then again, do you have a high LDL cholesterol or normal or borderline cholesterol? So as I told you, there is a certain set of population you don't calculate the risk. You start immediately. So when Dr. Ahmed Alsarraf say above 5, nobody would have 5 millimole unless you are really heterozygous, at least heterozygous familial hypercholesterolemia. So any familial hypercholesterolemia, you should start treatment from day one. Any patient with diabetic who completed 10 years, then you should start treatment. But pre-diabetes, if there is no other complication, then you have to calculate the risk using one of the calculator. If you are moderate and above, then yes, you have to start treatment. But the target would be different. For a pre-diabetes, if you are at a moderate risk or above, then you have to reduce LDL cholesterol below 3 millimole per liter, unlike diabetes, below 1.8 millimole per liter. Okay. So you start the treatment if you are moderate and above, and then the target would be 3 millimole. Otherwise, the first line treatment for diabetes, why pre-diabetes? They have usually obesity or they have metabolic syndrome, insulin resistance. So again, exercise, weight reduction. And then if it's not successful, then you would go for the statin.
Okay, thank you.
Actually, Mobarak, this is a very big topic to argue with. Unfortunately, many patients pre-diabetic, they start glucophage. Okay? And this is a big problem. We don't know when they are shifting to diabetes. So because pre-diabetic, there is nothing called pre-diabetes. Treatment is therapeutic lifestyle. Okay, because sometimes you don't know when they are going to turn to diabetes. So once they are turning to diabetes, you classify them as moderate risk, and the target should be below 3 millimole for LDL.
Before we end the day, for our competition enthusiasts, it's your moment. Scan the provided code and submit your answers quickly. The first 3 correct entries will be rewarded. Before we end the day, for our competition enthusiasts, it's your moment. Scan the provided code and submit your answers quickly. The first 3 correct entries will be rewarded with exciting prizes. Scan the QR code, then type your name. Okay, our first question, what's the name of the most common used quality control rules? Is it A, quality assurance rules, Westgard rules, or C, quality control rules? Our second question, which of the following is an example of limiting inappropriate use of lab test? Application of minimum retesting interval. B, repeating all abnormal test results. C, tests are done without a lab request. Yeah. The third one, which of the following is a common nutritional deficiency in post-bariatric patients? Is it potassium, CRP, or vitamin B12? Everybody's done? Okay. Yeah. Abdulrahman's the first one. Yeah. Good job. Okay, yeah. Dr. Abdullah.
So as we conclude today's session, sincere gratitude goes out for your engaging contributions. See you tomorrow. Thank you. Thank you so much.